Yeah, so we have Dr. Jyotirmay Biswas, respected, most eminent uveitis and pathologist. So welcome you for the next session. It's an honor to have you with us. We have Dr. Co-Chair, Dr. Kasturi, Dr. Santosh Mahapatra, and Amit Raj, Dr. Amit Raj. I hand over the mic to you as the moderator. Dr. Biswas, can we start?
Yeah, please.
Okay, sir. So may I invite Dr. Kirtana as a first speaker for today, a rare case of metachronous mucinous adenocarcinoma in the upper lid. I would request all the presenters to be seated in the first row so that you don't have to take the time to walk and come. We can save some time. Thank you. And please keep up to your time, okay? 4 minutes is your time. 4 minutes timer, please. Thank you. Audio visual. Sir? 4 minutes ka timer. Thank you.
Good afternoon to all, respected dignitaries. I'm Dr. Kirtana Vijay. I'm presenting a rare case of metachronous mucinous adenocarcinoma of upper lid and OSSN. Multiple primary malignancies was first described in 1879 by Bill Roth. The North American Association of Central Cancer Registries classifies multiple primary malignancies into two categories. First one is synchronous, in which the cancers occurs at the same time, and metachronous, in which the cancers follow in sequence, that is more than 6 months apart. Here we describe a rare case of a 37-year-old male with metachronous mucinous adenocarcinoma upper lid with ocular surface squamous neoplasia. He presented with complaints of mass in right eye upper lid since 6 months, gradually progressive in nature, not associated with pain, discharge or bleeding. He also had a raised fleshy growth in right eye white part near the limbus since 4 years, not progressing in size. There was no history of any ocular trauma or previous ocular surgeries, and patient had no known comorbidities. On examination, ocular symmetry was lost due to mechanical tosses and mass on right eye upper lid. The mass was of size 2 into 0.5 centimeter, involving the lid margin and extending 0.5 centimeter above it and horizontally extending from center of upper lid to lateral canthus with irregular borders and overhanging edges, firm in consistency. On slit lamp examination, right eye had a raised fleshy lesion, 0.5 into 0.5 centimeter size near the nasal limbus, encroaching the cornea and with engorged feeder vessels. The clinical appearance of the lesion was not correlating with basal cell or squamous cell carcinoma, so incisional biopsy from right eye upper lid mass was done and sample was sent for histopathological examination. The HP report of the mass showed subepithelium with pools of mucin, hyalinized stroma, and tumor cells arranged as tubules, glandular structures with oncocytic cytoplasm and pleomorphic nucleus, suggestive of mucinous adenocarcinoma, primary or metastatic. Right eye OSSN was excised and amniotic membrane graft was placed. Here we can see the fibrous septae, tumor cells arranged as glandular structures and pools of mucin. Patient was further investigated for gastrointestinal and seminal tumors, and primary malignancy was ruled out. Patient underwent wide local excision biopsy of right eye upper lid anterior lamellae. Posterior lamellae was left untouched. Sample sent to HP for clearance of posterior margin. Tarsal plate of right eye upper lid left intact. Free skin grafts were placed and right eye upper lid reconstruction was done. Here we can see the wide local excision with free skin grafts. Primary mucinous adenocarcinoma of eyelid is a rare malignancy with an incidence of 0.07 per million. First described by Lennox et al. In 1952, its incidence is more common in Caucasian males with median age of presentation being 6 and 7 decades. An exceptionally rare neoplasm with a propensity for local recurrence and metastasis and slow rate of growth, which leads to delays in being brought to medical attention. Accurate diagnosis of PMA requires a high index of clinical suspicion and accurate histopathological diagnosis. It should be suspected particularly in patients with recurrent eyelid lesions and must be differentiated from metastatic disease. A word about OSSN. Ocular surface squamous neoplasia is used to describe neoplastic epithelial abnormalities of conjunctiva and cornea. It ranges from squamous dysplasia to invasive squamous cell carcinoma. It is mostly unilateral and is seen in middle-aged and older patients, usually presents as a fleshy, gelatinous elevated lesion. Complete surgical excision with 4 mm margin clearance, no-touch technique is the treatment of choice. So upper lid is a rare site of mucinous adenocarcinoma for which successful surgical intervention was done, achieving adequate margin clearance, very good cosmetic outcome and patient satisfaction. Surgical removal with continued regular follow-up examination is the treatment of choice. Here is the patient immediate post-op and 3 months post-op. These are my references. Thank you.
You did any mucin staining was done like Alcian blue or colloidal iron?
Staining was not done.
Mucinous staining. Okay, mucoepidermal carcinoma is one of the carcinoma has been described in the lead conjunctiva, even the lacrimal sac, where you will get that mucoepidermal carcinoma. But I have not seen the adenocarcinoma of the muco thing.
Upper lid.
Any comment?
Yeah, this is a very nice presentation. Only one thing in mucoepidermal carcinoma, especially when it occurs in the periorbital and the lead region, it is highly metastatic. Like the MSI, the microsatellite invasion is very high. So have you done any examination of the lymph node or any PET scan, anything like this to know the MSI?
Lymph node examination was done, ma'am. USG was done. There was no other lesions. X-ray was done. But PET scan was not done, sir.
This is essential to know the microsatellite invasion.
Yes, ma'am.
Yeah, excellent, Kirtana. Very nice case. And as ma'am said, it's good to systemically evaluate. So you call it primary, right? So you have to always rule out secondary. I know most of our patients cannot afford a PET scan. That is probably why, because in a government setup, we usually do an ultrasound B scan, a chest X-ray or a chest CT scan. But I think PET scan is becoming a little bit more affordable currently.
Yes,
in government setup, you know, they get it done even for 10,000, less than 10,000 K. In private setup, it's around 18 K. So it's a little bit of effort. Just go explore the possibility of it. This is for all the audience, so it's always good. Good that you presented this case. We're always aware of, you know, sebaceous gland carcinoma, basal cell carcinoma, squamous cell carcinoma. So even a sweat gland tumor can arise, and most of these time, it appears as like a cystic translucent area. You know, it could be an apocrine cyst or an ecrine cystic lesion. So we often leave it there, you know, until and unless it doesn't have a stark appearance of a squamous or sebaceous or basal cell. Sometimes we give an option to the patient. It's okay, it's cystic. You can observe what you want. But all these lesions should be excised, you know, and especially something which is growing progressively. So there is an entity called sweat gland carcinoma, sweat gland tumors, which should be aware of, although it looks very benign and cystic. Thank you.
It's a benign.
So we go on to the next presenter of the day. So may I request Dr. Ritesh Verma, the unusual suspect, retinoblastoma. Over to you.
So very good afternoon, everyone. So I'll be talking about enigma of a case, which is a 22-year-old male, which presented to us for a second opinion. Can you? Okay. So just to give you a context, he presented with a gradually progressive painless blurring of vision from the past 2 months, which was associated with floaters. So he came for a second opinion after he was advised the vitreous biopsy, and he was advised intravitreal antifungals with antibiotics, and there were all sort of diagnoses on the previous slips. It was a tuberculoma in some or a choroidal abscess, and he underwent these battery of tests. So on examination, the visual acuity in the right eye was 624/N36, and the left eye it was 66/N6. The pressures were normal, and the anterior segment was unremarkable in the both eyes. So on posterior segment, you see there is a tortuosity and dilatation of the vessels in both superior and inferior quadrant. You see this some yellow subretinal deposits, and you then see some floating white vitreous spheres. So on wide field imaging, you can see there is a large mass in the periphery, which has a subretinal component, which has an epiretinal fluffy component, and there are multiple floating vitreous spheres. So on B scan, you can see there is a corresponding hyperreflective mass, which has, you can see both the epiretinal and the subretinal component, and the vitreous component as well, and this is a little subretinal fluid. So at this point, our diagnosis was whether it's an adult onset retinoblastoma or an amelanotic melanoma. So points in favor of the retinoblastoma was that there were multiple subretinal and vitreous seeds, and it has a moderate to high internal reflectivity. So we diagnosed it as a group D retinoblastoma, and we went ahead and do an OCT scan, which showed us the same, the subretinal as well as the epiretinal spheres, with a minimal subretinal fluid in the macula. The anterior segment was normal on the ES OCT, and on MRI you can see there is a lesion which is hyperintense on T1 and hypo on T2. The optic nerve was normal, and there was no intracranial extension, and there was a minimal contrast uptake. So at this point, we offered the treatment plan to the patient, and we went ahead and did enucleation in this patient because this patient was from a far off place, and he did not want to come back for the multiple sessions of chemotherapy. So we were not really sure what to do in this case, so we went ahead and did an enucleation. After enucleation, you can see on histopathology, it was confirmed it's a round blue cell tumor, and IHC was positive for synaptophysin and chromogranin A, and there was a high Ki67 index. There were no high-risk features. So what makes this case challenging is, number one, the pathogenesis. So there are two possible explanations for retinoblastoma in an adult patient is whether there was persistence of some embryonal retinal cells, or it was a spontaneously regressed or arrested retinoblastoma which was reactivated. So this is another patient of a retinocytoma or a spontaneously regressed retinoblastoma, wherein you have this area of calcification as well as some atrophic retina. So we did not see this in our patient, and there was no family history as well. So we diagnosed it as a de novo retinoblastoma from persistence of embryonal retinal cells. So another challenge was the misdiagnosis. There are 35 odd cases which have been reported earlier, and there are all sorts of misdiagnosis. Another thing is the classification, the ICRB, which has been proposed for the retinoblastoma classification. It is only for the children, not for the adults. So whether these treatment options and classification is valid on the adults, we are not really sure. And there has been one large series by Dr. Swati Kalki in which only there was one globe salvage in isolated 30 cases which they presented in a study. So there are a lot of unanswered questions regarding the genetic makeup, the globe salvage, and the long-term survival of these adults. So we don't really know what to call this case, a retinocytoma or a retinoblastoma. So this really makes our case a challenging and a rare scenario. Thank you.
I have described three cases of adult onset retinoblastoma in Survey of Ophthalmology with review of literature. And the oldest of that was 32 years old. It's really a diagnostic challenge when you see a retinoblastoma in adults. Whether they start from a retinocytoma and then missed, and then at adult age they develop retinoblastoma is not really known. But this is a unique manifestation of retinoblastoma. But there are around 30 to 40 cases has been reported in the literature.
Yes.
3 cases by mine.
Even sir, that one of our patient who ultimately went to you, that lady, we are following her for almost last 15 years. We had done an enucleation, like we were in a diagnostic dilemma, it was sent to sir. Then ultimately, sir, you all had done a vitreous biopsy.
Yeah, we did a final aspiration biopsy.
FNAC was done, then ultimately she was enucleated, that I was enucleated, and no no chemo was given because it was not a high risk retinoblastoma, it was just I think retinocytoma, that was what you all feel, no? Retinocytoma converting into a malignancy. And she is with me for the follow for almost 15 years. And she's fine, otherwise she is doing very good. But I feel that I have seen 2 cases only till now, and both are females. So is it that it is more common amongst the females, or, sir, what is your thought?
I have got one male patient also. The female is, I don't think there is a gender variations, but the thing is how it has been, I don't think that it's from the childhood retinoblastoma growing in adult. I think it's a kind of some retinoblast cells is there which grows into that in adult stage, or from a retinocytoma which is missed and which is asymptomatic and later on developed retinoblastoma. So if they come with a vitreous said at this age, this current scenario, I want to really enucleate. I will try the chemotherapy.
Yes, yes, sir. Yeah.
We have also reported one case of adult onset retinoblastoma. In that case, we have done blunder. Basically, patient has given history of trauma, and we thought patient has panophthalmitis. So we have gone for evisceration. But during evisceration, it was found that there's some mass-like feature. So we have sent for histopathology, and it comes out to be retinoblastoma. It has been published in patient was around 27-year-old male. It was published in Orbit.
Have you done a vitreous biopsy or?
No.
No,
That
I'm asking it.
We didn't do a vitreous biopsy initially.
But you showed vitreous seeds. You
Yeah.
could have done a
So we were-
aspiration biopsy.
So because we were thinking of retinoblastoma, we were not really sure whether it will lead on to extraocular spread or not. So if we are thinking on the lines of retinoblastoma, you can go ahead with the ice ball technique, the same technique we used to inject in retinoblastoma kids. But we were not really sure at that time. So the patient already, he wanted enucleation. So we went ahead and did enucleation in this case.
Yeah, excellent case presentation. Retinoblastoma is something very dear to my heart. Yeah, so two things here. Like whenever there is a vitreous seed, adult onset retinoblastoma is very, very rare. All right. Whenever you find a whitish lesion and there is vitreous seeds, it's almost always retinoblastoma. So melanoma doesn't present with white seeds. Another thing that in adults that we should keep in mind is lymphoma or even leukemia. But lymphoma, again, you don't get this large lesion, and you had, hyperreflectivity in the ultrasound. So I don't think there is a diagnostic dilemma here, clinically. Now, when you talk about medulloepithelioma, which is yet another differential diagnosis, we call it as ciliary body medulloepithelioma, right? So most of these lesions are in the periphery. And when seed happens in ciliary body medulloepithelioma, it's usually in the anterior segment. Their presence with sago grain seeds in the AC, anterior chamber, not really in the vitreous. So vitreous seeds is mostly retinoblastoma, if not lymphoma, or very rarely leukemia. So that is how. Now, regarding the classification, that you actually used a sentence that the classification of retinoblastoma is for the children, which is wrong. Okay, retinoblastoma, although it is very, very common in children, it can happen in adults. Which is the oldest patient in the case report, if you have done a review of literature?
So I think it was a 55-year-old.
Yeah, so 62-year-old by Shields from Wills Eye Hospital. So the classification remains the same.
Okay.
Now that we have the TNM-H classification also as any other cancers in the body for retinoblastoma, so classification doesn't change for a child or an adult, all right? Yeah. And as Dr. Biswas clearly mentioned, we have so much of advancement in treatment of retinoblastoma. It was in fact a very small lesion with vitreous seeds. We should be able to counsel the patient, for chemotherapy and vitreous seeds, and treatment remains the same. Universally, worldwide, for an adult or a child. Depending upon the body weight and age, the dosage changes, but the treatment doesn't change. Thank you.
So for that statement, whether this ICRB classification, leads, the prognostic classification is same for the adults as well, that we, that's the point. The
Okay.
prognosis, whether it remains the same in adults as
Well, so every tumor behaves in a different way. Even in a child,
I think
not every tumor, behaves the same way.
I think
Sure.
for the final established diagnosis, either you should have done a vitreous biopsy for histopathology, or you should have gone for genetic analysis to establish that, yes, this is retinoblastoma only.
I think
Clinically it is
cytopathology
appearing, I agree.
important.
So vitreous biopsy probably not, because clinically it was a clear shot case of a tumor with hyperreflectivity and vitreous seed.
How are you sure? Even the lymphoma can have vitreous haze, it's true. But lymphoma can also have a vitreous, it will present as a white lesion with some of vitreous cells. But I still believe that without a biopsy, so should we start any treatment? What do you
I'm
say?
not in favor of giving treatment without biopsy. Cytopathology.
So in this case, probably there was hyperreflectivity in the ultrasound. That means there is some calcification there. And it's a tumor which is like very typical of a white lesion. with vitreous seeds and subretinal seeds also, which they, in OCT it was proven. So I personally wouldn't go for a biopsy. I mean, it's just my personal practice, yeah.
So we discussed all the options.
99% retinoblastoma.
So we discussed all the options with the patient, and finally he agreed for enucleation. So we went ahead with enucleation.
You have gone for enucleation.
Yeah.
Huh.
For that, then definitely you should have gone for histology of the enucleated.
So we did histopathology, sir.
Then
Came
we
at-
had done,
it
but
came as
before that, I think the
retinoblastoma.
globe could have been salvaged in case you had done a very aggressive treatment, because now to 95% salvage rate, they say, right?
Yes, ma'am, yeah.
The patient did not agree for follow-ups. He did not want the side effects of chemotherapy. So he wanted
Anyways, all the discussion, all the, right, but what I still believe, what Bishwas sir has mentioned, we should have a confirmatory diagnosis in any cancer. Because cancer is not an eye treatment, it's a treatment of the life. So we need to have a confirmatory diagnosis when that is what we practice, but there's always individual variations.
Thank you so much.
So we go on to the
next case.
Yeah, next presenter, Dr. Swada Kattiaini, a rare case of bilateral capillary hemangioma. Over to you, Dr. Swada.
इसको चेंज कैसे करें? नहीं हो रहा, नहीं हो रहा, नहीं हो रहा, नहीं हो रहा, पीछे कैसे जा रहा है? Good morning, everyone. My case is a rare case of bilateral conjunctival capillary hemangioma. No financial interest. Consent of the patient was taken. A 21-year-old male patient presented to IOPD with a reddish mass over upper conjunctiva covering the upper cornea in both eyes. Patient complains that the mass has been gradually increasing in size over past few years. Patient complains of diffuse reddish, painless, non-tender mass over upper conjunctiva in both eyes, which his mother noticed 1 month after birth as a small reddish mass, which has been gradually increasing in size over past few years. Patient also complains of diminution of vision more in the right eye than in the left eye since childhood. No limitation or pain on eye movement, no difficulty in closing his eyes due to mass. Past medical history, surgical history, family history were all non-remarkable except for the treatment history where patient was taking some non-allopathic eye drops. General examination, patient was also very fine. Ocular examination, in right eye, we saw visual acuity, best corrected visual acuity of 2/60, and in the left eye, 6/9. In rest, everything was fine. In conjunctiva, we saw bright, reddish, soft vascular mass coming from upper pharyngeal conjunctiva and encroaching over upper cornea with small feeder vessels seen over the temporal side. Same findings was also seen in the left eye as well. Only thing is that the size of the mass was 17 to 10 mm in the right eye, and in the left eye it was 15 to 10 mm. In cornea, in both right eye as well as in the left eye, it was clear except for the reddish mass covering 1.5 mm of upper cornea. These are the photoslit lamp pictures of right eye and left eye. Ocular examination, extraocular movement in both right eye and left eye was full, free and painless. No pulsation seen, no brute heard, but the mass glanced a little on pressure. Fundus finding in right eye we saw optic disc coloboma, and in the left eye we saw morning glory disc. We were suspecting some syndromic association in this patient, so we put patient on blood investigation. Everything was normal. In imaging study on ultrasound color Doppler was suggestive of bilateral capillary hemangioma. MRI brain and orbit was not very conclusive, though it showed increased anteroposterior diameter of bilateral orbit. No extension into the orbit was noticed. So we reached a provisional diagnosis of bilateral conjunctival capillary hemangioma. DD papilloma, cavernous hemangioma, and port wine stain. Management, we offered optical correction and medical management in the form of oral beta blockers. We started on oral propranolol with a low dose of 1 milligram per kg per day after physician consultation. Topical beta blockers, systemic steroids, and topical steroid drops. Other treatment options available are intralesional steroids, immunomodulators, laser photocoagulation, carbon dioxide, argon, neodymium, yak, and pulse dye lasers have all been utilized nowadays in the treatment of capillary hemangiomas. Radiation therapy, surgical excision, reserve where conservative management has failed or was suboptimal. Discussion, capillary hemangioma is the most common tumor of the orbit and periorbital area in childhood. Girls are more commonly affected than boys. Incidence of infantile hemangioma in general population is 5%. Capillary hemangioma is a hematoma composed of anastomosing small vascular channels without true encapsulation. Association are Maha, Kasabek-Marriott syndrome, Faces syndrome. Conclusion, my patient is a case of bilateral conjunctival capillary hemangioma with topical drops and oral beta blockers. Gradual decrease in congestion and size of the mass was noticed. Though we were in diagnostic dilemma between hemangioma and papilloma, as our imaging study was not very conclusive. So we tried mitomycin C as well, but the mass was responding more with beta blockers and steroids as compared to mitomycin C. These are my references. Thank you.
Go ahead.
So, any comments from your side? Can we just have the clinical picture of the patient, the conjunctival picture? Yeah. Excellent presentation.
Ma'am, we are
Congratulations.
still more in the suspecting. We were still in diagnostic dilemma between papilloma and hemangioma, but we are more in favor of hemangioma because patient is responding more with the beta blockers.
Yeah. Can we just have the picture? I mean, just to take you through. Yeah.
So,
Right, yeah. I'm not sure, hemangiomas are usually really vascular and reddish, right? Yeah. And with the morning glory association, so many things, something that I would keep as a differential diagnosis here would be a complex choroidal.
choriostoma.
Yeah, complex choroidal, which could be reddish if there is a lacrimal gland. Dr. Biswas would be the best person to talk about it. So that's what I would actually keep in mind. When you told me that beta blocker, there is a response. Do we have a post beta blocker picture? How much it has responded?
Did not came for follow-up.
Right. So this is the first thing that I would keep in my mind when I see this, bilateral, and then with disc anomalies and many other things going on in the child.
Yes, ma'am,
So
we haven't seen
Bilateral
such
capillary anemia is very unusual.
Yeah, ma'am, we haven't seen such cases anywhere.
Yeah, one thing you could have done is you could have done a biopsy, and it's excisable if you put an AMG there, and so you get a diagnosis. It also becomes a treatment, right? It's surgically excisable. I think so, right? I don't know what the posterior extent is, but I feel so. I don't know.
Patient was also not willing for to undergo any surgical procedure.
Yeah.
We were consulting him, but he didn't show up also.
Right. So choroidal is something that I would keep in mind. Thank you.
I think there is some publication of having a bilateral disc coloboma with choroidal coloboma and orbital hemangioma. So they are also in the conclusion, I think one of our friend Fasad's publication. So there are also conclusion that it can be syndromic, and that is what they have concluded. So this is very nice. You are getting, it's very, very rare, as sir has already mentioned, bilateral hemangioma, but Farsad's paper also says the same thing. So you should publish this. Provided you can prove it, it is a hemangioma. You need to prove it.
Yes, ma'am. Ultrasound was also suggested.
Ultrasound is not.
But it was not very reliable. We should be going for the. Yes.
Make you publish.
But you do a biopsy.
Okay, ma'am. But patient didn't follow. Came for the follow. We were planning to.
Loss to follow-up in this generation cannot be accepted, because every patient, when I see people from very low socioeconomic status, also they have a phone. Even the laborers who work, they have a phone, no? So
Mobile,
that mobile. So that tracking the mobile number and having the correct number is very important, especially old generation. No, in your time, loss to follow-up can be, accepted. In our generation, it is okay. But I always tell my students also, you cannot say that we are not. You have to follow the patient. You have to take multiple mobiles number. Like if you have something, a rare disease like this. Okay.
Thank you, ma'am.
All right. So we go on to the next presentation by Dr. Santosh, our respected panelist. Over to you.
Ready? So good afternoon, one and all. Very good discussion is going on. To add to that, here is a case. All that glitters is not gold. Picture of like papillophlebitis, but are you dealing with anything else than that? Here is a case of 26-year-old medico, known hypertensive, and presented to us with defective vision for 7 days. Had history of fever also 15 days back. Anterior segment was normal. The blood pressure, see him. The inflammatory disc edema, MAC venous dilatation and toxicity, perivascular seeding, retinal hemorrhages, microaneurysms with cotton spots. As he had a blood pressure of 150 by 100 something, the straight diagnosis came to the mind was grade 4 hypertensive retinopathy. But all the findings could not be explained with that, and I ordered for OCT also, which was almost normal except superficial hemorrhage in the superficial layer, along with disc edema. This fundus angiography showed disc hyperfluorescence in later phases and dilated tortuous vessels without any neovascularization, and blood fluorescence in some areas due to hemorrhages. So with this, I ordered for a complete hemogram which showed mild leukocytosis. Rest of the tests were normal. CT scan was normal. As because he's a young male with hypertension, I ordered for the ultrasound abdomen which showed splenomegaly, and renal parenchyma and renal arteries were normal. With this, I thought let us go for a blood smear. And this was the blood smear picture which showed cells in various stages of granulopoiesis, including promyelocytes, metamyelocytes, and segmented neutrophils. Then definitely we were suspecting some blood cancer, referred the patient to hemato-oncologist, who they have done a bone marrow aspiration cytology, and which showed hypercellularity with proliferating myeloid cells. So he was, after this, also gone for a genetic analysis for the blood, from the blood, which showed chronic CML with gene analysis of BCR-ABCL, and it was positive. Thank God it was a responsive blood cancer, and he was put on medications. This is 15 days after the start of the medication, and 1 month follow-up he had with us. Fortunately, he was complying to all the tests we are ordering as he was a medico. And this fundus picture shows almost clearing of all hemorrhages. So the disc is appearing almost normal, and visual acuity also has improved. So what does this case gives us to think about? Just you can have it as a just case of hypertensive retinopathy, but it's not. Maybe simple anemic retinopathy. Definitely leukemia was one of the diagnoses. He had a history of fever, so post-fever retinitis also was in differentials, and IRVAN and vascular occlusive diseases also. The moral of the story was first appearance can be deceiving, hence investigate to reach at a diagnosis and best possible management. Thank you so much.
Wonderful case. And this case gave it a lesson that you should keep a lot of differential diagnoses in many of the cases, like, starting from inflammatory pathology, neoplastic pathology, hematological disorders, etc. I had a patient who had presented with the used disease like picture, retinal vasculitis, and with capillary non-perfusion ischemia. When I was looking into the old pictures, I found that the presentation initially was a papillophlebitis only, and then subsequently developed used disease. So the papillophlebitis can be a presentation of inflammatory diseases like tuberculosis, like sarcoidosis, etc. Even syphilis can present like that. So wide array of differential diagnosis should be kept, and here you found a relatively older patient. Younger patients can have leukemic infiltrate. That's very well described, that disc edema and papillophlebitis in leukemic children. But in adult, finding this finding is quite a diagnostic challenge.
Thank you.
Yeah, excellent case, and you have really, come to the diagnosis. Yeah, so when we have a differential diagnosis of leukemia, this is going back to Dr. Verma's case also, when there was peripheral blood smear is something, very handy, which gives away the diagnosis. So having a papilledema, sir, Biswas sir, could there be an optic nerve infiltration also,
sure,
that we should be ruled out? Right, yeah,
this
yeah.
leukemic infiltrate in the optic nerve is actually this one of the cause, and this can be sarcoidosis can produce optic nerve infiltrate.
Right.
Adenomas.
Yeah, so optic nerve infiltration is something, yeah.
And the peripheral smear was done in our hospital only, in the eye hospital. So
Right.
it gave us the clue.
Right,
actually.
yeah. So PBS is something which is like straight away. We don't even have to go take even for an orbital, suspected leukemia. You do peripheral blood smear, you get the diagnosis. Nothing.
Very simple test, basic
very
test.
simple test, yeah.
By chance, this is a chance finding.
Okay, thank you.
Thank you.
So we go on to the next presenter. We have Dr. Subhav Prasad, and he will be telling us Grape of the Eye. I like your titles, by the way. Yeah.
Good afternoon, everyone. Thank you for the opportunity. I shall be speaking on grape of the eye, pluck it or preserve it. We had a 31-year-old lady who came in with blurring of vision in the left eye since 3 weeks. There was no metamorphopsia, no history of floaters or flashes, history of multiple prior ophthalmic consultations on which she was diagnosed to have a left eye retinochoroidal mass, but had no prior intervention. We had 4 arms basically, which involved clinical examination, an ultrasound biomicroscopy, a B scan, and a systemic evaluation, which was negative for metastasis. Clinically, there was no regional lymph node extension. This is a slit lamp photograph which shows a well circumscribed mass extending from 8 o'clock to 12:30 position, which is pigmented, which was negative for transillumination, but we might be thinking in terms of a benign lesion here at the initial presentation. But to show you next, please have a look at the dilated episcleral vessel and a small focus of an extraocular extension. Gonioscopy confirmed our findings of an angle invasion. Ultrasound biomicroscopy, we at the baseline, we measured for the height, width, and also the base of the lesion. At this point, we are dealing probably with an intraocular malignancy, and the flip sides of the coin to manage this would be conventionally to go ahead with the enucleation, where we have the other option being a plaque brachytherapy. But what were the challenges we had? We had an angle invasion, a peripheral iris invasion, and an extraocular extension in the form of a transcleral spread. So we went ahead with a customized plaque brachytherapy in consultation with the radio-oncologist, where the dosimetry for the lesions are decided based on our measurements. And you can see a 2-month follow-up. If I were to just go back to the previous slide, where we have this as a lesion at the initial presentation to what is seen 2 months later following a plaque brachytherapy, is a significant reduction in the lesion size, which was further followed up 2 years later. I'm really sorry for this photograph because it's a poor quality image following gonioscopy. We had taken this photograph, and sequential UBM measurements also showed a reduction in the size of the lesion. Ciliary body melanoma, it constitutes to about 6% of the uveal melanomas, and the most common presenting symptom would be a blurring of vision, which also should be a take-home point, that a simple blurring of vision in a young individual should not be taken lightly or requires a very, very comprehensive assessment. It is diagnosed late as the lesion remains hidden, and ciliary body tumor has a 2 to 4-fold increased risk of metastasis as compared to other posterior uveal melanomas. So 2 things to look at: where did we start and where are we at now? To start with, we had an intraocular malignancy, difficult to explain to the patient, possibly thinking of eye removal, which again becomes a social stigma. And third, most importantly, the systemic spread. Whenever dealing with an ocular malignancy, think in terms of life salvage first, second ocular salvage, and last the vision. Now, we have a patient whose vision was salvaged, globe was salvaged, and there was no metastasis. Thank you.
So,
do you consider keeping a possibility of ciliary body melanocytoma?
Yes, sir.
Yeah, like as Sir mentioned about retinoblastoma biopsy, was a biopsy done here to prove it?
No biopsy.
Okay. Yeah.
Clinical diagnosis, on the basis of the clinical diagnosis, you have started the plaque brachytherapy, right?
Yes, ma'am. Clinical yes, ma'am.
But when we talk about melanoma, like you have yourself mentioned that the life is first, then the globe and the site, right?
Yes,
have you
ma'am.
done any systemic workup,
Yes, ma'am.
any PET scan?
Yes, ma'am. We did a whole body PET CT scan, which is negative for metastasis, ma'am.
I saw the regression pattern. It was something like a collapsed, like, we see the peripheral iris cyst kind of a thing.
Yes, ma'am.
The thing which is like hanging there, yeah.
Yes, ma'am. Peripheral iris pigment epithelial cyst, yes, I would think of if I was not seeing a sentinel vessel and I was not thinking a transcleral spread. But typically, if you were to look at that lesion, which is well circumscribed above the horizontal meridian, initially my impression would have been a IPE cyst, ma'am.
Right.
And there's
when it
transillumination
collapsed,
negative.
after the treatment.
Yes, ma'am.
Right, yeah.
UVM is a very good test in such cases. UVM is the crucial, very crucial UVM.
It's from a ripe grape to a shrunken one, ma'am.
Sorry?
It's from a ripe grape to a shrunken one.
Yes.
And didn't pluck it yet.
All right. Any more questions from the panelists? Any discussion?
As you have described, blurring of vision is one of the important early symptoms.
Yes.
What are the early signs that one can suspect that you may be dealing with a case of ciliary body melanoma?
So, comprehensive clinical science per se is only on our clinical assessment. Now, for example, if I were to deal with ciliary body melanoma, usually remains hidden. But if I'm looking at the anterior segment, say a
Any
slit lamp.
pupillary sign?
Yes, sir.
Absence of pupillary.
I'm coming to it. I'm coming to it. If you were to look at the anterior segment examination, and if I'm able to see a neovascularization of the iris, if there is any chorectopia and any heterochromia, and presence of any nevi on the iris and all that, I am thinking in terms of a marker which can progress towards my thought in terms of a malignancy. And also do look at the anterior chamber depth. In certain advanced ciliary body melanomas, there can be angle breakthrough or anterior chamber breakthrough or iris extension as well. So if on slit lamp examination, if the AC is of the anterior chamber, is of not a uniform depth,
Uneven.
then I would be if there is a fullness in one particular quadrant, go ahead with gonioscopy, look at the angle structures, possible invasion, non-visualization of the angle structures in those terms, sir.
That's good. Thank you.
Thank you.
Excellent presentation.
Melanocytoma or a melanoma, both will respond well to breaking, right?
Ma'am.
So till now we don't have a conclusive diagnosis. It can be a melanoma or it can be a melanocytoma. Or do you feel that no, it is a melanoma, not a melanocytoma?
Not definitely that I would pin it down only to a melanoma, ma'am. I would also consider the differential for a melanocytoma, ma'am.
Supposing it is a melanocytoma,
Ma'am.
do you still prefer a breaking?
Weighing the pros and cons, yes, ma'am. If
Yes, in a melanocytoma.
not in a melanocytoma, if I definitely know it is a melanocytoma, no, ma'am.
So in that case, do you suggest that we need to have a pre-treatment any diagnosis?
I would go for a biopsy. Actually, I would go for a biopsy. I have described the case of melanocytoma of the ciliary body in long back in survey of ophthalmology, which has got a prolapse of uveal tissue prolapse. And that was debated quite a long time, and we didn't have that much invasive modality of it's an imaging modality. It's a long back.
So is there any very characteristic feature where you can differentiate melanoma from melanocytoma in UBM?
UVM, I am not sure.
All right, yeah.
In that case, you suggested we should do an FNAC.
Yeah, basically melanocytoma, again there are dense pigment, melanoma doesn't have dense pigment.
Yes,
So
yes.
sometimes you'll have that in the angle whenever there is a melanocytoma in the ciliary body or the iris, you have dense pigmentation in the angle. So that is one clue that you can always look for. Even thinning can happen in melanocytoma also because if it grows progressively, right?
Ma'am.
Great. Let's go to the next case presentation. Yeah. May I request Dr. Anjula Kumari? Ocular manifestations of leukemia. Yeah, over to you. Thank you.
Good afternoon, everyone. Myself, Dr. Anjula Kumari, here to be present my topic, ocular manifestation of leukemia masquerading as the orbital cellulitis. It's not working. No conflict of interest. The 2-year-old child presented with a painless progressive unilateral right side proptosis with a restricted ocular movement with the right side zygomatic maxillary fullness, 10 days duration. There was no history of the trauma, fever, joint pain, and no history of the spontaneous bruises. There was no significant ocular history, past medical history, family history, and the patient, he was the low socio-economic status. The systemic examination was within normal with no recess, no adenopathy. On ocular examination, we have seen in the right eye, the patient do not follow the line, restricted movement, extraocular movement in all quadrants with the proptosis, chemos conjunctiva, exposure keratopathy with the mid-dilated pupil, and we couldn't find see the posterior fundus due to the corneal head.
But in the left eye, we have found within normal except for the subconjunctival hemorrhage. So come to the differential diagnosis, the orbital cellulitis. This was excluded because there was no any ocular trauma and any history of the paranasal sinus hemorrhage. Rhabdomyosarcoma is also excluded, and the metastatic neuroblastoma. So come to the investigation, we have seen the hemoglobin was decreased, platelet count was decreased, and the elliptic FT, every investigation was within normal with increase in the CRP level. MRI scan, we have seen the posterior superior lesion reaching up to the orbital apex with the soft tissue bulges in the region of right temporal consecutivity, mildly encasing the cavernous segment of right internal carotid artery with significant luminal narrowing. These findings suggestive of the lymphoma and rhabdomyosarcoma. So go for the incision biopsy, which was negative for both the lymphoma and the rhabdomyosarcoma. Now come to the peripheral blood examination for the immature cell. We have seen there was the differential leukocyte, the blast cell 45% we have seen, and platelet count was reduced. So impression was the acute lymphoblastic leukemia, and go for the bone marrow examination. Here also we have seen the 39% of the blood cell morphology suggestive of acute lymphoblastic leukemia. The diagnosis was made on the peripheral blood smear and the bone marrow examination, we saw the blood cell. So most common malignancy in the childhood were 2 to 10 years of age. Lymphoblastic leukemia which arising from the lymphoid precursor cells of bone marrow lympholytic system, and it was the medullary and the extramedullary involvement which affect the multiple of the organ. The leukemic presentation associated with the orbital mass is usually obscured in the acute of the myelogenous series. So to come through some articles, we have seen the some article presented with the ALL. The primary level is the diagnostic challenge for the physician. So the blast morphology and the immunophenotype in the precursor B cell, we have come to the diagnosis with the peripheral blood smear and the bone marrow examination. So high degree of malignancy suspicion in case of the pediatric patient presenting a proptosis, imaging modality can possess the diagnostic challenge. Peripheral blood smear in these cases can play an important role in the diagnosis. Right diagnosis at the right time is warranted for the optimal management in these patients. So take home message is the ophthalmologist should be aware of the unusual ophthalmic manifestation of acute lymphoblastic leukemia. Thank you.
Excellent presentation, and you have really stressed the message,
Yes,
in your presentation. So a child presenting with a proptosis, in fact when you saw right eye, obviously it's a very evident
Yes,
proptosis, but left eye also has some kind of fullness, right? If you
yes,
have
ma'am,
seen.
some kind of illness, but we have
Right.
seen only subconjunctival hemorrhage, nothing else.
Nothing else, yeah.
Yes, ma'am.
And the patient overall, if you see the child, very frail. If you look for
Like I-
palpebral, conjunctiva, there will be some amount of anemia. So the message is so very clear. In childhood proptosis, something that you have to really rule out is leukemia. And the only thing that you have to do is peripheral blood smear. We don't even go in for a biopsy and start the treatment. Sir, Biswas, sir.
Could,
Yeah, please.
could you see the fundus? In this case,
Yes,
do you
sir,
feel-
I have seen the fundus, but it was the very short period of time he had gone.
You could have
And-
taken a picture.
Yes, sir.
You could have taken a picture of the fundus. Because people have seen dilated in that photo I saw.
So in the right eye, I haven't seen because of the hazy cornea, but in left eye, the fundus findings which was normal.
I'll share something very interesting. My first publication with sir on chloroma. So this child, he came with us repeated inflammation of the superior rectus muscle. So every time we give steroid, it goes down. So then when we are wondering why it keeps on recurring, and PBS was normal, peripheral blood smear, everything was normal. Then we had done a biopsy. It's way back, 20 years back. At that time, we did not have a ocular pathology department, so it went to sir. Then sir calls me up, he says, Kasturi, this is chloroma. And I tell sir, PBS is normal. Then we had done a bone marrow biopsy, and it came out to be positive for leukemia. So bone, in case you have a suspect, and interestingly, all this leukemia, it responds very good to steroid.
Yeah.
So even if you do a biopsy, if you think in a child or anyone, you have to stop steroid at least for 3 weeks. Then only you have to do a biopsy. Very recently, a same thing happened to us. We give steroid, it goes down. PBS is normal. And then it was a picture something exactly like lymphangioma, but there was a bony erosion. So we were not sure. So, and the moment I had just put the needle, I could see the chocolate cyst type blood coming. So I was thinking it would be lymphangioma. And then I have also given bleomycin. And the patient responded so well, it has just gone off. But later when there was a recurrence and we had done a bone marrow biopsy, it came out to be leukemia. So sometimes it might mislead you when you suspect a leukemia leading to any of the orbital lesion. No, bone marrow should be done in case the PBS is normal.
Excellent point, ma'am. And stop the steroids. Yeah, steroids can mask the bone marrow finding as well as a peripheral blood smear. We'll go on to the next presentation. Yeah, we are kind of running late, but it's a lunch break. I think we'll manage it, yeah. May I request Dr. Anupama Sharma on the dais for the next presentation. Choroidal osteoma.
एक मिनट डाउन कैसे होगा नेक्स्ट स्लाइड ओके ठीक है
Running late. No questions, yeah. Let's do it quick.
Okay. Very good afternoon to all of you. Today I am here with a very interesting case of choroidal osteoma with secondary choroidal neovascularization, a case report. Our case is a 37-year-old female who came with chief complaints of diminution of her vision in both her eyes for last 8 months. Her diminution of vision started in her right eye first, followed by the left eye over a period of 2 to 3 months. It was painless, gradual, progressive, and was associated with distortion of images. There were no history of redness or photophobia or trauma. The past history, family history, and personal history were not significant, and she belonged to a lower middle class. On ocular examination, visual acuity in both her eyes were 6/60, which was best correcting to 636 in her right eye and to 612 in her left eye. Rest of the anterior segment findings were within normal limit, including the intraocular pressure, which was normal in both the eyes. On fundus examination, in both the eyes, there were adjacent to disc, there were yellowish to orange-red lesion, subretinal lesion, which had a geographic border, and it was slightly elevated with vascular branching over the lesion with some pigmentary changes. There were also grayish patch over the macula. With all these, the differentials we kept as were choroidal osteoma, choroidal melanoma, choroidal metastasis, choroidal hemangioma, and posterior scleritis. To streamline our diagnosis, we did certain routine investigation like complete blood count, random blood sugar, lipid profile, serum calcium, and serum alkaline phosphatase, which all came within normal limits. On OCT macular examination, there were subretinal hyperreflective lesions along with subretinal fluid in the right eye, and there was no subretinal fluid in the left eye. But there was a breach in the RPE Brooks membrane area. On fundus fluorescence examination, it showed early hyperfluorescence and late leakage and staining in both the eyes. On B scan, there was a flat choroidal lesion with very high reflectivity and acoustic shadowing, giving a pseudo-optic nerve sign in both the eyes. With all these, we came to a diagnosis of choroidal osteoma with secondary choroidal neovascularization in both the eyes. For treatment, we started her on anti-VEGF bevacizumab in her right eye, and for left eye, we kept her on observation. On subsequent follow-up, there was regression of the choroidal neovascular membrane along with the resorption of the subretinal fluid. We did follow-up over a period of 6 months, and after giving 3 intravitreal injections of anti-VEGF bevacizumab in her right eye, the best corrected visual acuity was 6/12 in her right eye, and there was no progression of lesion in the left eye. And we saw regression of choroidal neovascularization and subretinal fluid in the right eye. Coming to discussion, choroidal osteoma is a rare benign ossifying tumor of unknown etiology. It typically presents as unilateral lesion. It is more common in healthy young females in their 2nd and 3rd decade of life. It is usually located in the peripapillary and juxtapapillary region and may extend to the macula. Most common complication of this being the choroidal neovascularization. in treatment modalities, the treatment is mainly directed towards the complication arising out of it. That includes anti-VEGF treatment, laser photocoagulation, and photodynamic therapy. To conclude, choroidal osteoma is a rare tumor but has got vision-threatening complications. Hence, early diagnosis of these complications and timely intervention can help prevent significant visual morbidity. These are all my references. Thank you.
Thank you so much, Dr. Anupama.
You could do an CT scan and it will show brilliantly the bone lesion.
Yes, sir.
So we have Dr. Radha Ramanan here. So we have one more presentation to go, 4 minutes. Are you okay with the presenter going up? 4 minutes. If you give us the permission, we'll. Is it okay? Okay. Rolika, you have to say thanks to him. Thank you very much, sir. So we're going to have a quick last presentation by Dr. Rolika. Thank you, and we will discuss this outside during the lunch, okay? Yeah.
Thank you so much, sir, for allowing.
You have to be,
I'll be quick.
yeah, 4 dot.
So I'll be extremely quick. My presentation is Where Flowers Bloom, So Does Hope. And I thank my mentor for giving me the opportunity of seeing such beautiful and rare cases. So a 42-year-old female presented to us with blurring of vision in the right eye since 3 days. And it was associated with mild pain. It was a very vague symptom. And she was referred to us by a general ophthalmologist who had noted raised pressure. And there was no history of any systemic issues or any history of glaucoma in the family. So we have kind of had vague symptoms and we had to put it all together. We went ahead, we assessed that there is absolutely normal vision, 6/6. She's just complaining of blurring. Very nicely, if you notice, she has an anisocoria in the right eye of a difference of 2 mm. And the pressure to us, when she presented, it was 18 mm in the right eye, and left eye it was 16 mm, not on any topical medications, and also there were iris pigments on the anterior surface of the lens. Very closely we went in, zoomed in, and we saw a flower-shaped iris lesion in the inferotemporal quadrant. You can see there was 1 clock hour involvement. There was a small hyphema on the upper edge. We zoomed in further, and then you can see that there are iris pigments on the surface of the lesion and on the lens, and there's a minor tractional fold on the surface of lens, which is basically causing the anisocoria. We went ahead, we assessed on anterior segment UBM, and we saw a height of 1.87 mm and a maximum width of 1.97 mm. And this is basically, we call a raster view, so that we can see if there is any other cystic lesion in the iris, because these kind of patients have a tendency to have multiple lesions. And we went ahead and we put all of these things together and came up with a diagnosis of an iris hemangioma. So basically these are iris hemangiomatosis, which are acquired benign vascular lesions comprising of coiled vascular loops arranged in tufts. These are basically called Cobb's tufts or iris vascular tufts, first described by Fechner and described as multifocal vascular tufts by Cobb. These are 2% of all iris tumors. Histopathologically, it is basically aggregates of small, thin-walled blood vessels. Myotonic dystrophy and diabetes mellitus are common associations seen. Routine slit lamp examination is enough. We can see spontaneous hyphema and increased IOP in these patients. It is crucial that in cases with spontaneous hyphema, increased IOP, we must look at the possibility of NV and NVI. And this patient, it was clear. We could not do a fluorescent angiography and OCT angio, which we did not have for anterior segment, but rapid hyperfluorescence with late staining is seen in these patients. So we have options like observation, topical management, and surgical intervention. So observation and topical management is still okay. Surgical intervention is definitely not mandated, not advocated. In this patient, we chose to go ahead with topical management, or I would say rather observation, and I'll explain how. So moving on, just 1 second. So this is how the patient presented to us after 6 weeks. After 3 months, you can see slowly the color is changing. It is nicely coagulating, and this is beautiful. After 6 months, it is nicely coagulated. The attractional component has reduced, and even the dimensions have improved majorly. So to conclude, you can see excellent results in these patients. We put the patient on topical timolol. That was enough because we kept the high IOP in mind, and also timolol has a beta blocker effect, and therefore the patient improved we put it on twice a day regimen, and the patient responded extremely well. So if asymptomatic, it can be left to be observed. If symptomatic, topical management suffices, but regular follow-up is definitely mandatory in these patients. Thank you, and thanks a lot for the wonderful session.
Thank you, Dr. Rolika. Yeah, so I thank the panelists being here, especially Dr. Biswas, who has given his valuable time in enlightening us with his knowledge. And thank you so much. And thank you, Ramnan sir, for allowing us. Yeah, we started late, but that's not an excuse.
Session, that is Populate 2. And on the chair, Dr. Amit Shah. I think he has missed his flight yesterday. Dr. Radharamanan is here. Dr. Sharad Babu.